Important safety information for Aggrastat, tirofiban hydrochloride injection. Indication: Aggrastat is indicated to reduce the rate of thrombotic cardiovascular events, defined as combined endpoint of death, myocardial infarction, or refractory ischemia, repeat cardiac procedure in patients with non-ST elevation acute coronary syndrome. Contraindications of Aggrastat include a known hypersensitivity to any component of Aggrastat, a history of thrombocytopenia with prior exposure to Aggrastat, those with active internal bleeding or a history of bleeding diathesis, major surgical procedure, or severe physical trauma within the previous month. Warnings and precautions. Aggrastat can cause serious bleeding. Most bleeding associated with Aggrastat occurs at the arterial access site for cardiac catheterization. Minimize the use of traumatic or potentially traumatic procedures, such as arterial and venous punctures, intramuscular injections, nasotracheal intubations, etc. Concomitant use of fibrinolytics, anticoagulants, and antiplatelet drugs increases the risk of bleeding. If bleeding cannot be controlled, discontinue Aggrastat. Thrombocytopenia, discontinue Aggrastat and heparin. Bleeding is the most commonly reported adverse reaction. For additional information about Aggrastat, please refer to the full prescribing information. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088.
Hello, my name is Kevin Ariani. I'm an interventional cardiologist, mainly working at Dignity Northridge Hospital and Providence, Cedars-Sinai, Tarzana, and West Hills Hospitals in San Fernando Valley. I am the cardiovascular service line director at our hospital, and I'm going to present several cases using Aggrastat as a bailout for intracoronary thrombus, which developed during or pre-PCI. Purpose of these videos are for typical use of Aggrastat for fellows in interventional cardiology who might not be fully familiar with contemporary use of 2B3A inhibitors. Here are my disclosures. I have received financial support from Medicure to create these video series. First case is a patient of mine, 66-year-old female. She has extensive history of coronary disease. As well, she has hypertension, hyperlipidemia, diabetes. She's been experiencing typical chest pain. We performed a nuclear test and a large anterior reversible defect was found. Initial coronary angiogram revealed a severely calcified lesion in the proximal to mid LAD. We performed diagnostic angiography, as I mentioned above. We proceeded with intervention. For that, we used an FL 3.5 guiding catheter and heparinized the patient, period. A rotational atherectomy was done on the vessel. Following that, the wires were changed and a 15/3.0 non-compliant balloon was used to perform angioplasty. And following that, we successfully deployed a 24mm/3.0 synergy stent, period. Following shots, as you see, reveals slow flow, and immediately an intravascular ultrasound imaging was done, which revealed significant amount of intra-arterial thrombus. Before going through the next steps, as a refresher, Aggrastat or tirofiban hydrochloride, it is a reversible antagonist of fibrinolytics. It binds to the glycoprotein 2B3A receptor. Where it blocks is the final common pathway to platelet aggregation. Half-life is short, around 2 hours. and after that, platelet functions return to normal. And usually it takes a full 4 to 8 hours when we have complete normality of the function of the platelets. Aggrastat is potent and provides rapid platelet inhibition. And the response of it throughout patient population has been shown to be very consistent. More importantly, through its mechanism of action, Aggrastat has the ability to disaggregate an existing thrombus. This is very important. It is neither an anticoagulant like heparin, nor is it a P2Y12 inhibitor. And none of those as well can do this step, which is disaggregation of an existing thrombus. So there are limitations to what thrombus can be done to disaggregate it. Typically, we can do it only on a fresh thrombus. Let's go back to our case. This is how we proceeded to management and getting resolution to the thrombus. We administered a bolus of Aggrastat of 25 microgram per kilogram. Following that, we started the patient on an infusion of 0.15 microgram per kilogram per minute. After this was started, we advanced a 2.5 by 12 millimeter over the wire balloon to distal LAD. We did this to ascertain that we are in the true lumen and as well assess how much of the thrombus we are dealing with. Angiography was performed. As well, we infused 100 microgram of nitroglycerin through the balloon inside the artery. On the way back, although the balloon was of a small gauge, we performed few inflations. Subsequently, we performed the final infusion of contrast into the artery, showing that we have full patency and TIMI grade 3 flow. Patient was asymptomatic after this and was transferred to recovery room. These are some takeaway notes from this case. 1, Aggrastat can be used in rescue mode. 2, in this case, treatment of intracoronary formed thrombus after stent placement, Aggrastat was successful to disaggregate a fresh thrombus. Furthermore, Aggrastat provides adequate antiplatelet therapy, while an oral antiplatelet agent was loaded for this patient. I'd like to thank you all for watching this case. And if there are further questions with respect to Aggrastat, please don't hesitate to contact your Aggrastat team for more information.